Could you please provide your name, qualifications, current affiliations, and your area of research expertise?
My name is Ian Francis. I'm an ophthalmic surgeon. These days I only do 2 operations though. That's temporal artery biopsies and chalasia. And I qualified in medicine at Sydney University with MBBS, and I have fellowships of the Royal Australian College of Surgeons, Royal Australian College and New Zealand College of Ophthalmologists, American Society of Ophthalmic Plastic and Reconstructive Surgeons, Australian and New Zealand Society of Ophthalmic Plastic Surgeons, and I've got a PhD from UNSW on watery eyes. I also got an Order of Australia Medal, lowest grade, for services to ophthalmology, for teaching and visiting overseas, operating and teaching. My current research is just writing up everything that we do write up. We had 19 publications last year, including one in Clinical and Experimental Optometry on temporal arteritis, So far in August this year we've had 7 publications, and we expect quite a few more this year. I don't think we'll make 19, but it'll be close. And currently I'm just concluding a Doctor of Science. That's a postgraduate degree that follows the PhD, and it's focused on cataracts.
Thanks for that, Ian. Could you please give us a brief explanation of what temporal arteritis is?
Well, temporal arteritis is an autoimmune disease that has association with many systems, but as far as ophthalmologists and optometrists goes, it's neuro-ophthalmology, so that it affects brains and eyes. And it's neuro-ophthalmological in the sense that people go blind, and the usual thing is they present with headaches, blurred vision, jaw pain, night sweats on a Friday, and people think, well, this could be temporal arteritis. I'd better do some bloods over the weekend, and they do, and the patient returns blind Monday morning. That should be avoided at every possible point. But it also affects every single organ system in the body.
And further to that, what is the clinical presentation of temporal arteritis?
Well, we've just published a document that has the 39 steps to clinical diagnosis, and we've got 3 more that have just come along. But basically, patients with temporal arteritis are older, usually in their 70s or 80s. They're more commonly women in 2/3, and they have episodic visual loss, including amaurosis fugax and diplopia. They have jaw claudication, and they have new headaches. This isn't a patient with headaches for years. This is a patient with new headaches. There are lots of other abnormalities too. We've described in a published pro forma, which is good for leaving in clinics and so on, so people can get the idea quickly and remember it and ask some of the questions. It's remembered by the mnemonic TAB. T stands for tongue, and they get tongue ulcers. A stands for aortic root, and they get aortic regurgitation and rupture of the aorta, aneurysms of the aorta. And they get B, which is breast lumps, which resemble closely carcinoma of the breast because they're often fungating and ulcerating, but they respond to steroids because they're due to temporal arteritis.
Who's considered to be most at risk from this disease?
The people most at risk are women in their 80s, but men are affected just about as frequently. But it's never been shown to occur in a patient under 40, and it doesn't occur in children.
If a patient was to present with the symptoms of temporal arteritis to an optometrist, what would your advice be as to the management of the condition?
Well, the first bit of advice is to ask the patient what they're experiencing. And as I've just pointed out, the top 3 symptoms of temporal arteritis are loss of vision and diplopia, new, generally severe headache, and finally pain in the jaw when they chew. Pain in the jaw is not pain in the temporomandibular joint, but in the muscle. It's a kind of ischemic pain, a bit like a claudication in the leg or cardiac pain. We should take a comprehensive history, and if the optometrists like to have a copy of the temporal arteritis profundium, they can get it, stick it up on a wall, and they won't forget any symptoms, because the more symptoms, the more likely it is the patient has temporal arteritis, and the more likely the optometrist is to be able to start treatment, start investigations, not let the patient go blind or die. The things to be tested in the examination are the pupils, and classically a patient with a central retinal or branch retinal artery occlusion will have a relative afferent pupil defect, and especially we'll have one of those when the patient has arteritic anterior ischemic optic neuropathy due to the temporal arteritis. They can have ulcers on their tongue, as mentioned, so it's worthwhile looking at their tongue. They can have ulcers on the scalp, and there are about another 40 odd symptoms and signs which are important. But the pupil side is most important for a relative afferent pupil defect. Patients are sometimes reluctant to discuss double vision or episodic loss of vision, but those are two hallmark symptoms of temporal arteritis. And so if I had done a cataract, the patient's usual best corrected vision at 1 month following surgery is 6.4 in 93% of patients, and I think your optometrist should get that. Then if they're over 85, in which case 6.5 or 6.6 is acceptable, then any patient should have 6.4, and if they don't, they've got several things: macular degeneration, possibly cystoid macular edema, the wrong implant, corneal decompensation, or perhaps temporal arteritis. If you find a relative afferent pupil defect, then you have to look for ischemic retinopathy or ischemic optic neuropathy. So the optometrist is right up to it with here. Then the pupil should be dilated, and you can see the branch retinal artery occlusion or the central retinal artery occlusion, or more pertinently, the swollen, pale, congested optic nerve, which differs from the red congested optic nerve of non-arteritic anterior ischemic optic neuropathy. So if you make the diagnosis as an optometrist, this is a medical emergency. It's the one true emergency in ophthalmology, I believe. And those patients need to see their GP or go to ED and get on some IV steroids, have the bloods, and have a biopsy. Of course, the relevant bloods are a full blood count, which includes a hemoglobin, which can be down, a normocytic anemia, platelets, which can be quite high, and of course ESR, which can be very high, as can CRP. The doctor will always go through all these findings when the patient arrives at the hospital. One of the things I've been teaching people lately is to ask the patient whether they have chest pain and to listen for a moment called aortic regurgitation. And if they've got that, then it's even more of a medical emergency.
Given everything you've just said, and it really sounds like this illness presents as a bouquet of horrors, how is temporal arteritis effectively treated?
Now, for treatment of temporal arteritis, the diagnosis is critical, but rapid treatment is perhaps even more important. If they have visual symptoms like diplopia or amaurosis fugax, I recall one patient whom we saw recently who was in hospital already with a diagnosis of temporal arteritis. They'd done the biopsy, had done the bloods. He was a classic case. He was about 80, something like that, 85. And when he complained of loss of vision in one eye, that should have been the initiating an event to get him treated a bit more aggressively. Well, they put him on a dose of about 60 milligrams of prednisone, or 50, which is a sort of a not quite homeopathic dose, but not very high. And the reason he could see loss of vision in this eye of his was that was the only eye that was working. The other one was already blind and had that pale, swollen, congested optic nerve of arteritic anterior ischemic optic neuropathy. So, given all that, he needed more steroids, and I suggested to the doctors that he have a gram of intravenous methylprednisolone, but that's 100 milligrams a day depending on weight, and then go on to high oral dosages. He should also have some oxygen, because that might improve his circulation to his optic nerve, and he also needed to have an anticoagulant. Such a patient with all the features of temporal arteritis needs to have their aortic arch looked at, and so a cardiologist needs to be involved very quickly. We sometimes progress to tocilizumab, which is a biologic drug, if the prednisone isn't working or the prednisone is giving too many side effects.
Is temporal arteritis one of those conditions that progresses slowly at first, and then if it's not caught in time, it really ramps up? Or does it just suddenly turn up and is really bad right from the get-go?
This temporal arteritis, its presentation is quite variable. But I think if a patient presents with some of the symptoms, and you've got 39 plus those 3 I mentioned as well, then you have to listen to the patient, get the diagnosis, and think about his or her aorta and visual symptoms. And there's a very strong case to be made, as I hinted already, that the patient shouldn't be just seen on Monday and have the bloods on Saturday and see how you're getting on kind of thing. The patient should be helped immediately and as powerfully as you can. So you've got to get the patient to a hospital on a Friday afternoon. In that way, the bloods, the treatment, and then the biopsy can be commenced rapidly. Now, as I said, I only do 2 operations these days, a temporal arteritis, temporal artery biopsy, and I can do that any day of the week, pretty much, because that's the only operation I do. At the best of time, I'm surfing or playing drums or mucking around with the grandchildren. Anyway, so I would say that temporal arteritis is the single most serious disease we see in ophthalmology. It can kill the patient and it can blind the patient quite easily. And if you see somebody, take the history, get the diagnosis and get them treated. No self-respecting ophthalmologist or even ED person, emergency department person, would knock you back if you say a patient's got this disease.
Thanks again, Ian, for taking the time to sit down and conduct this interview with us for the next issue of CXO. From everything that you've said, it's very clear that temporal arteritis is a serious disease. It's hard to catch, it's hard to treat, it progresses very fast, and the symptoms are so varied that you really need to be on top of things to be able to catch it and be able to catch it quickly to prevent the worst and get the best outcome for your patients. So thanks again.
Thank you.